have a blood gas of 7.40, PaCO2 of 40, PaO2 of 50, bicarb of 24, and the patient's saturation is 85% on the current settings. First, interpret the blood gas. You can pause the video to do this. Second, determine if you have an oxygenation or a ventilation problem, or both. Now decide which parameter you would like to move to improve your blood gas. So this patient has a normal acid-base status with moderate hypoxemia. So which ventilator settings or non-invasive ventilator settings would you like to move to improve oxygenation? There are two variables to change to improve oxygenation. You can pause the video and then resume. If you chose EPAP or FiO2, you were correct. You could increase your EPAP by 1 or 2 to improve your blood gas oxygenation. So in this circumstance, we could go from 5 to 6 or 5 to 7. But since my patient is only on room air and I'm on 10/5, the first move I would actually make would be to increase the FiO2 and supplement that patient with some oxygen. And what is the maximum amount of oxygen that we want to try and stay under? You want to stay under 50%. So for this patient, you may find that you want to go to about 30%, 35% to achieve a normal PaO2. Now we'll do another blood gas. Again, interpret the blood gas. You can pause the video. This patient has a normal acid-base status with hyperoxemia. So what moves would you like to make with this patient to affect the oxygenation status? If you answered EPAP or FiO2, you were correct. You would drop the EPAP, say to 4, or reduce the FiO2. It's not wrong to do a combination, but typically therapists will do one move or the other and then assess. And it really depends on how much FiO2 you're on. If you're under 50%, the likelihood to increase FiO2 will be the first move. If you're close to 50% or over, you would not increase the FiO2, you would increase the EPAP as long as blood pressure was stable. Let's do another blood gas. Interpret the blood gas. Pause the video. This blood gas is a partially compensated respiratory acidosis with normoxemia. What is the disturbance? Oxygenation or ventilation? You may pause the video. If you guessed ventilation, you were correct. What parameters would you change to affect ventilation when in non-invasive bilevel ventilation? Pause the video. If you chose IPAP or respiratory rate, you were correct. You can increase the IPAP by 2 or 3. Evaluate the new tidal volume and minute ventilation for the desired target minute ventilation. Or you can increase the respiratory rate to overdrive the patient's effort to increase minute ventilation. The preferred move would be to increase IPAP so that the patient is able to continuously synchronize with the machine. I'm going to return the rate back down to 12. Let's do another blood gas. Interpret the blood gas. Pause the video. If you interpreted this blood gas as partially compensated respiratory acidosis with moderate hypoxemia, you were correct. Is this disturbance ventilatory issue or an oxygenation issue or both? Pause the video. If you said this was a combined ventilation and oxygenation issue, you were correct. What parameters would you change on the non-invasive ventilator to improve the blood gas? Pause the video. To improve the blood gas ventilatory defect, which is a high CO2, you could increase the IPAP or increase the respiratory rate. To improve the oxygenation status of the patient, you can increase the EPAP or the FiO2. Let's try another blood gas. Interpret the blood gas. If you interpreted the blood gas as partially compensated respiratory acidosis with hyperoxemia, you were correct. Is this a ventilation issue, an oxygenation issue, or a combined problem? Pause the video. If you said this was a combined ventilation and oxygenation problem, you were correct. To correct the ventilatory defect, the patient is hypercapnic. To better ventilate the patient, you could again increase the IPAP or increase the respiratory rate. Increasing the IPAP would increase the patient's tidal volume. Increasing the respiratory rate would increase the overall minute ventilation. The patient is hyperoxemic, so the FiO2 must be decreased. If our patient were on 80%, we could drop the FiO2. In this case, I would go to 60%. Let's try another blood gas. Interpret the blood gas. Pause the video. If you interpret this blood gas as partially compensated respiratory alkalosis with normoxemia, you were correct. Is this a ventilatory or an oxygenation problem? If you said this was a ventilation problem, you were correct. What parameters would you change to improve the ventilation defect? If you chose IPAP and respiratory rate, you were correct. This patient is hyperventilating with a low PaCO2. You would decrease the IPAP or decrease the respiratory rate to decrease overall minute ventilation. Let's try another blood gas. Interpret the blood gas. Pause the video. If you interpreted this blood gas as partially compensated respiratory alkalosis with moderate hypoxemia, you were correct. Is this a ventilatory or an oxygenation problem? Pause the video. If you said this was a ventilatory and an oxygenation issue, you were correct. What parameters would you change in order to fix the ventilatory and oxygenation issues in this blood gas? Pause the video. If you stated you would decrease the IPAP or decrease the respiratory rate to increase the PaCO2 and correct the respiratory alkalosis, you were correct. If you said, increase the FiO2 to correct the hypoxemia, you were correct. Let's try another blood gas. Interpret the blood gas. Pause the video. If you interpreted this blood gas as partially compensated respiratory alkalosis with hyperoxemia, you were correct. Identify if this is a ventilation or an oxygenation problem. Pause the video. If you stated this was a ventilation and an oxygenation problem, you were correct. Which parameters would you change to correct the blood gas? Pause the video. If you said that you would decrease the IPAP or decrease the respiratory rate to help compensate for the respiratory alkalosis and raise the PaCO2, you were correct. If you said decrease the FiO2 to correct the hyperoxemia, you were correct. Let's look at the waveforms on the bilevel ventilator on the current standard settings. We have a pressure curve when the patient breathes in. We have a volume curve that shows us how much volume per pressure, and then we see the flow of the patient. Down here you can see the average tidal volume for this delta pressure change of 6, which is giving us about 600 to 700 mLs per breath. And we see the IPAP go up to 10. I'm going to change the scalar on that pressure curve here. So we're going to go into scale, and we're going to change the pressure scalar because we're going to end up increasing our pressure. Hopefully we don't have to change the volume, and the flow should be fine with what we've got. So we're going to keep those parameters and go back. Now, if I increase the IPAP amount, you will see the patient's ventilation should increase. So their volume, the delta pressure change went from a delta pressure change of 6 to now a delta pressure change of 8. So that's like having from the difference between 6 of pressure support, and now we've increased it to 8 of pressure support. And you notice the scalar goes up higher where the pressure curve is, so above there. And look at our volumes here. We're at 1100 mLs per breath on the volume. So just moving by 2 on the IPAP has significantly increased our tidal volume size. Say we wanted to decrease tidal volume. Let's, instead of being on 12 or 10, where at 10 we were getting 600 to 700 milliliters, let's go down to an IPAP of 8 with the EPAP of 4. Now our delta pressure change is only a difference of 4. So the pressure support amount is 4. Now look at our tidal volume sizes here. So the patient's tidal volumes dropped to about 400 versus 600 to 800 with the pressure of 10 and 1,000 milliliters with that pressure of 12. So you see how increasing delta pressure or decreasing delta pressure will increase or decrease your tidal volume.